In Kentucky, there are really only two cities that have and offer high quality care for aging people that may experience memory and thinking. That's Louisville and Kentucky, or Lexington. And if you live in any of the more rural or remote regions of Kentucky, there are no resources available for you. No trained specialists, no caregiver support specialists, and we have a wealth of resources here at the Sanders Brown Center on Aging and the University Alzheimer's Center that we wanted to push out and make those services available to people across the state of Kentucky, from Paducah to Pikeville. People in more remote areas of Kentucky simply will not drive to Lexington, despite the issue of being able to receive perhaps higher quality health care or the services that we have to offer. It's not just gas. There's actually a hesitation. And so we need to bring those services out to the people of Kentucky. And I cannot hop in my car and drive all over the state every week. I'd never get any work done. Telemedicine allows me to see a patient in Paducah at 9 o'clock, and at 10 o'clock switch over and see someone in Hazard. At 11, switch over and see somebody in Owensboro. I can jump around the state and interact with patients, providing high quality of care in a way that I simply couldn't do without this technology. We've taken the concept of clinical practice in the telemedicine setting and really expanded that, trying to accomplish academic goals of not only high quality clinical care, but also research and educational outreach, those three shields of academia, so to speak. I've managed to submit a proposal and be funded by the Alzheimer's Association to do just that. And so, in addition to providing clinical care, we're collecting vital information from these clinical encounters that are informing us on modifiable risk factors for memory and thinking problems as one ages that may differ between rural and urban populations in Kentucky. The second arm of that project is using mock telemedicine interviews to establish the validity of the work that we're doing. In essence, we put a patient in one room and we're in the room right next door, but only allowed to see each other over the TV set and communicate with one another. And we've found that the depth of the interaction is incredibly equivalent to the in-person interaction. The only thing I can't do is actually lay my hands on a patient. We're validating both the measures that we use, the cognitive test measures, as well as the physician diagnosis, and so far we're finding almost a perfect correlation. The third component of that is the educational outreach, and 4 times a year we broadcast across the state of Kentucky an educational program that would otherwise not be available to anyone outside the Louisville or Lexington area. We're holding these sessions in conjunction with the Alzheimer's Association, and they typically are comprised of 15 or 20 minutes of myself or another physician presenting on the medical aspects of degenerative disease, and then 15 to 20 minutes with our social workers and Alzheimer's Association staff providing caregiver support and caregiver training. We did sessions on dining disasters and bathing battles and the issues that people really face in their homes on a day-to-day basis, issues that really can impact quality of life. We then open up the forum for discussion, questions from Pikeville, from Murray, from Hazard, from Moorhead, all over the state. We've actually brought together a community that can interact via the telemedicine system to help one another to become educated and to improve the quality of care for people with Alzheimer's and related disorders. It's very intimidating at first, and intimidating for me anyway. I'm not sure about the patients, but I recall my first few telemedicine interviews. It was often a bit awkward to be on the other side of the television set. And it takes about 2 or 3 sessions before I really began to feel comfortable, to see that there really were no barriers. Now I try to engender myself to my patients that I'm meeting for the first time, because if you can put them at ease, the interaction becomes as comfortable as you and I sitting here talking with one another. I usually like to tell people how wonderful they look on the big screen, like a movie star. That often warms them up, breaks the ice, and then we can move on with the critical issues and details required to help them clinically. I couldn't do what I'm doing for people throughout the state without the telemedicine system. Anyone who has an interest in moving what they do here in our academic institution, our tertiary care setting, out to the real world, to people across the state, really would benefit from using this technology. I don't see any other way to do it. Holding a remote clinic and driving out to Paducah one day a month and to Owensboro one day a month would not give me the same freedom and accessibility to populations across Kentucky that the telemedicine system affords.